Okay, welcome everyone. Today we have a wonderful session on caring for seniors with Robert Campbell, who is an MD, and Lisa Warner, who is a PA, and Brianna Tanny, who is a PharmD. The three of them are going to give a lovely presentation today, and we'll have people trickle in, and I'll have them introduce themselves and tell a little more about their presentation today.
Hey, thanks guys. Thanks for coming. As he said, I'm Robert Campbell. I'm a med-peds physician in Augusta, Georgia. And I started the clinic that I work in back in 2007. I've been working there ever since as a physician, now as a chief medical officer. And there's only one thing probably that I love more than like helping create programs for seniors and for just for the clinic in general. And that's like talking to students. And that's why I was a little bit late, because I was down there at that student thing. And I'm so glad to see so many young students at CCHF. It's a beautiful thing. I was introduced to this ministry and this kind of work when I was a first year med student at the University of Illinois. And it's just imagine, your lives and the way the beautiful things that you can be doing as you look around this conference, and caring for seniors is one of those things. This is something that's near and dear to my heart because I think it's because it's near and dear to God's heart. And God wants us to care for the vulnerable and to care particularly for the elderly. And he gives us this great vision in Zechariah for what this should look like. And the Lord Almighty says, once again, men and women of ripe old age will sit in the streets of Jerusalem, each of them with cane in hand because of their age, and the city streets will be filled with boys and girls playing there. Like this beautiful vision of the beautiful community where people are well taken care of and people have the things that they need. They have a cane, they have their DME, but they just are at peace. And they have community around them, and that's you've seen pictures of that, I'm sure, in your own lives of people that you know in those kinds of settings. And then, of course, you've seen the lack of those things, in your health centers or in your neighborhoods or in your own families, maybe, where there are folks who just don't have that community and don't have those resources, and so I won't take too much time because I want to introduce our wonderful speakers who are going to do the bulk of the presentation, but there are these wonderful, beautiful ways that we can make things better for seniors in our communities. And we have two great examples in front of us. But these are some of the issues that are facing seniors in our community. And the image on the right, what I want to point out is that we have an aging population around us too. So this is something that we as God's people need to be cognizant of, and we need to be intentional about, in thinking about how can this is going to be a growing issue in our culture, in our community over the next, 20, 40 years. So let's be prepared for it, and let's do the best that we can with the resources God gives us to address it. There are more seniors in poverty, and there are more seniors in the homeless population. The cost of care is going up, even with Medicare. There are staffing shortages, both just in primary care in general, but particularly primary care that are senior facing. And there's this, what they call an unpaid burden of just family caregivers trying to provide care at home for seniors. And then there's just lots of isolation, and we know isolation increases the risks of dementia, depression, heart disease, all the things. When you're isolated and you face depression, there's all kinds of biological, physiological things that happen that make us sick. And so there's lots of isolation and lots of just difficulty in navigating things with the digital divide with seniors. My mother is in her 80s, and it's very difficult for her to do anything, because of most things are online. And so that's a real challenge for seniors. And even like when we think about operationalizing things in our clinics, like, oh, this could be a lot more efficient. We'll put all our forms in digital. Okay, that's good. but it can also be bad, or, oh, we'll just do it all, everything online. Well, okay, that's good, but a lot of people don't have online, or if they do have online, they don't understand how to really, use it. So let's just think about it. So anyway, that's my brief introduction outside of introducing the core of our discussion today. And that Lisa Werner and I started talking about this talk, I don't know, a couple of years ago, maybe at Global Health Missions Conference. Yeah. And then maybe here too. Like every time we'd see each other, we'd say, hey, wow, what are you doing in Chicago about, for seniors? And she's telling me all this stuff. Like, that's amazing. Like, we should talk about that. And then I'd go home and I'd talk to Dr. Tanny, about what we're doing in Augusta for seniors. I'm like, gosh, we're doing some great stuff, and our seniors are doing so much better. We should talk about that. We're figuring some things out. So Lisa, she can tell you a little bit about herself, but I'm going to just let you know that she's at Lawndale Christian Health Center. They take care of a lot of people in Lawndale, 50 to 60,000 individuals every year. They do 180, 200,000 plus encounters every year. They have a lot of clinic sites that are woven through the community. And she's framing this out as pursuing the joy of God in caring for seniors. Dr. Tanny, Brianna Tanny, she's a PharmD. Dr. Tanny's been with Christ Community now for maybe 5 years. She's our Director of Care Coordination. And we at Christ Community in Augusta, Georgia, take care of about 11,000, a little over 11,000 individuals each year, about 45,000 encounters. We have we have 5 clinics and 3 sites. And so she's going to talk about how we've operationalized senior care through scalable models of coordination. So, and she'll talk a little bit about that because it's expensive and it's difficult, and trying to figure out coordination is some kind of a challenge. So I'm going to turn this over to Lisa.
Right. Thanks so much. Nice to see everybody here. This has been a kind of a daydream of mine to share some of these approaches to caring for older adults. A little bit about me. I grew up always with a little bit of fascination with older adults. I loved my grandmother. And as I became a PA in my practice, I drew more and more into the realm of geriatrics and really fascinated by people's stories and learning from them. And I feel like there's just this repository of wisdom right before us, right, that that's relatively untapped. And so I'm hoping that as you take some things away here, that there are approaches and ideas I hope to help sensitize you to some of the unique challenges and gifts that come with treating the older population, and also simple things that you can take to your practice as soon as Monday, and maybe even train some of your staff, as well as thinking about other models that you can maybe implement into your health system. Okay. So I'd like to start off with, this is in the geriatrics world. It started off as the 4Ms about 15 or 20 years ago, and it's graduated to 5Ms now. But this has been developed as a really, I think, helpful framework as you're thinking about any sort of work or attempt to take care of older adults. The elements that might be helpful as you think about whether this is your own practice. We are actually taking this at Lawndale and adapting this to the templates for our initial assessments for our older adults. But I've seen this adapted in hospital settings. I've seen it adapted to QI projects related to sepsis, for example. And I think this is a really good place to start. Thinking about some of the peculiar and unique challenges that older adults may face, thinking about what's happening in the mind and cognition, thinking about what's happening with their mobility and some of the challenges that come along there. Oftentimes folks have many medications, so polypharmacy, those are issues to take into consideration. And then I love this. There's a real focus these days in geriatrics on what matters most. Having these conversations really directly with your patients and figuring out what are the things that really matter to them and making your practice focus a little bit on that. And then multi-complexity is the 5th one that was added, just recognizing that people come with so many needs oftentimes, in addition to the clinical picture. So I'm going to talk just about simple physical spaces, I hope you can go back to your clinic spaces and with new eyes, look at your spaces. I want to think about parking, waiting room, walkways, and exam rooms. So parking is a big deal and a big problem in the west side of Chicago at Wando Christian Health Center. As we've grown and more people, as we're seeing more patients, there are not necessarily more parking spaces that are growing. So this is a picture actually of our senior clinic, and there's a parking lot right next to it. But I have had regularly, I worked in that senior clinic, and I would have patients call me and say, I drove around for an hour and I could find a parking spot, and they missed their appointment. And so it's a real issue that we have to deal with. But some of the things that we have implemented are just signs. Again, this is intended to be very practical. Real signs are signs that protect those spaces. Senior citizen parking, for example. And then this meant, you can see here, this is a patient parking lot alone. But I will just comment that because this is so convenient to the clinic, it's also very convenient for staff. And so part of the challenge we have is to help prioritize these spaces for our older adults in particular. When you're thinking about your waiting room, you want to think about the space. This is the variety of mobility devices that people might be bringing into your space. You got to have room. You got to have room to be able to maneuver these things in and around. And you might say, oh, ADA regulations have made accommodations for this. And to some extent, that is true. But I would argue that there are additional challenges that many of our older adults regularly encounter, that's not quite sufficient. So thinking about your entryways, are there any steps, like back at that, from the parking lot into our senior clinic? There's actually a step there that you just have to account for and make sure you're watching out for that. One of the things we think about are the chairs in the waiting room. You want to have chairs that have a broad seat wide enough for people to sit in, and then arms in order to lift themselves up. And I would just say, one of the things we learned, in our senior center, actually, we have chairs that do have arms, but the arms are only 3/4 of the length of the chair. And so the mechanics of putting your hand behind your back and lifting yourself up are actually still challenging with that. So we're having to replace our chairs in our senior center because we didn't think about that. Of course, your walkways, think about your doorways. It's really tough if you've got a rollator and you got to open up a door to get in and out of a hallway. So thinking about, we put automatic openers on our bathroom doors in our senior clinic, for example. Your exam room, you got to think about, again, these mobility devices. In addition to, oftentimes people come with caregivers, so having enough space for caregivers to sit in there. I put a picture here of an exam table. We just had a patient go over to the hospital, and she was in a wheelchair. She was limited for mobility-wise, and they said for her test that she had to get, the nurse literally said, now you need to get out of this wheelchair, step up on this chair, and sit up on the exam table. And of course she couldn't do it, but I was shocked at the hospital's inability to accommodate her, right? So when you're thinking about your own exam tables, we have focused on they're almost like recliner chairs that you sit in that are actual exam tables that can lower, they can raise, and then we have also added phlebotomy arms. So we think about the flow of the patient through the clinic. Somebody who doesn't have mobility issues, you're just thinking about optimizing your space in your room, the time in the room, and that's relevant. But for our senior patients, it was actually simpler for us to do blood draws inside the exam room. Something you want to think about is just communication tips that you can train your staff to do. I won't read through all of these, but things like age-related hearing loss, the frequency that is lost with age-related hearing loss is the higher frequency. And people tend to, when they're speaking to older adults, When they talk, when they talk louder, they raise their voice, and that's actually not so helpful. So we train our folks to, when you're talking louder, to lower the tone of your voice so it hits the lower frequency, and that's a more effective way of communicating with folks like that. I often, when I'm sitting in the exam room, I will sit in a chair knee to patient. You want to get on their level. Try to avoid masks if you can. These days that's harder, but try to do that, because all the peripheral communication things are utilized in folks who have hearing and eyesight impairments, and worth considering. So I'm going to talk about 4 different models that we've employed at Lawndale that are trying to address some of these unique needs of our older adults. Some of the folks are here. Adelaida is in the back. This is actually a picture of her. She didn't know she was going to be in the picture. So one of the things, I'm going to talk about these models in order of complexity. So this is kind of the simplest model. We started this about 15 years ago with one nurse practitioner. We found that a number of our patients, our older adults who'd been with us in our primary care clinics, started having things like strokes or starting to develop dementia and could not make it into their regular PCP visits. Historically at Lawndale, the providers each had the capability to run over to somebody's house and do that, but we formalized this and actually made a way that we could continue to see these folks in their homes. So the home visit program was born, and I worked in that for a number of years. We historically, like I said, staffed it with one APP. When I came on, we were taking on more patients, and I was trying to think about efficiency. So we hired an MA. We actually purchased a vehicle, and then we outfitted it with, as my husband says, a little ambulance back there. We put supplies back there. And I put these on for any of you who are interested in some of the structural sort of ways you do this. Our productivity is around 6 to 8 people we could see per day. Our reimbursement, there are actually home-based codes you can utilize, and especially within Medicare. And we calculated we were about break even at about 6 per day. Okay, 6 visits per day. We were about break even. Your impact, your benefit is clear. These are folks that would not otherwise see folks. They're not getting to specialists. Really, the decision making they are making at home is, do we need to go to the emergency room or not? So I dealt with a lot of wounds. I dealt with a lot of folks who with dementia. I took care of patients to the end of their life, did some palliative and co-management with hospice. But what a gift that has been to continue that relationship with these folks as they were homebound. During COVID, we decided to start a geriatrics clinic, and the construct we created is that for 65 and older, we could take on patients from anywhere in our clinic. We could, by referral, have a PCP who felt uncomfortable either continuing to manage highly complex older adults as they aged, or they could consult the folks in the geri clinic for things like a dementia workup or that sort of thing, and they could go back. You can see the staffing is real similar to any sort of clinic team that you create. The productivity, we really wrangled with this a little bit, but we did 30-minute visits. So we were seeing somewhere between 12 and 14 patients a day. Of course, the reimbursement, just like any clinic, is various based on the kind of insurance or uninsured status of your folks. But it was really impacted by the hierarchical coding. The risk-based coding helped to make that work sustainable. And we, as a part of that, have coordinated care folks in there. We have a care coordinator that almost acts like a social worker-esque, limited in many respects, and a referral coordinator who would help to navigate things like transportation and appointments, that sort of thing. I wanted to mention an adult day program. This is not clinical. This is actually a brick and mortar building that is funded through the Department of Aging in every state. You take on folks, you have vehicles, you have a day center, and you provide meals and activities. There's very limited nursing support for some med administration, but beyond that, your reimbursement is based in the state on a per participant sort of basis. And then, of course, this is all about avoiding impacting social isolation. So providing socialization activities and a place for folks to come. There's some limited ability to keep people on once they become more dependent with their ADLs and IADLs. And so at some point, typically people have to leave the program because it requires too much assistance. And lastly, I will talk about the granddaddy of models, in my estimation, of care for older adults. This is a program of all-inclusive care for the elderly. We use the term PACE. It's in 34 states. There's about 190 programs around the U.S. It's not really well known, but Lawndale started this about a year and a half ago. Now, this is a CMS, Medicare and Medicaid funded project that is a full risk arrangement with the facility, that's us, and then we take on all the risk for all the care services that are provided and offered through Medicare and Medicaid. So again, we utilize a day center. So that's part and parcel of this. You have a day center that provides all the services that Adult Day did, that I just showed you, that senior day. But in addition to that, it has integrated clinic services and a therapy gym. So from day one, CMS requires that we have a team of 11 different disciplines around the table. We meet daily, and we are very, very involved both in the home for all the home care services, their nutrition, all of their clinical coordination, all their transportation. It's the most comprehensive, all-inclusive care model I've ever seen. I've never seen anything like this. It's deeply relational. We get to know these folks really, really well, for good and for bad. Sometimes they get tired of us, that's for sure. I just put up, this is just kind of a model to show all the things that PACE gets involved in. And happy to talk more about that. There's lots to say about that, but I want to hand it off to my colleague.
Thank you. I'm going to try not to scream at you guys. All right, I am Dr. Brianna Tanny. I am the Director of Care Coordination at Christ Community Health Services, like Dr. Campbell mentioned. I don't know why they put me behind Lisa because my presentation will not be as interesting as hers, but just be patient with me, please. But honestly, I think what we just saw from Lawndale and what Lisa described is a really good example of what's possible when you're intentional about, creating an environment for seniors to thrive. What I want to do is just take it a step further, build on that, and talk about what it looks like to operationalize that in a primary care setting. And we want to do that in a way that doesn't add additional burden to our already stretched out clinical staff. So at Christ Community, we were faced with this challenge, like how do we create a model that's financially sustainable, that is scalable, that is efficient, right, but meets the needs of our seniors. So that's what I'm going to go over today, kind of what it looks like in practice at Christ Community. All right, so I know you've heard it, I know you've seen it in all of your clinics. Our Medicare population and our seniors are getting increasingly more complex, right? We're not just managing chronic conditions, we're managing chronic conditions and behavioral health needs and social barriers and isolation and limited support systems. And traditional medical care is still very highly fragmented. So there's care spread across primary care, specialists, home health pharmacies, with very little communication between all those different facilities. And really, it's just because the day-to-day hustle and bustle of clinical care makes coordination a lower priority in those settings. So our goal, like I said, is to create a model that's scalable and sustainable, but actually is relational and responsive to the needs of our seniors. A model that equally prioritizes operational excellence and measurable outcomes. Our solution at Christ Community was built around this idea that we still want to have continuous team-based care. So we were attempting to move from a model that had episodic care to continuous care, one that had siloed physicians to multidisciplinary teams, but to do that in a financially sustainable way. All right, so what does a better model look like? You know, like I said, we built our model around this idea of continuous team-based care, and we did that through a few core programs. We started with chronic care management, which I'll go into a little bit deeper in a few slides. We also added remote patient monitoring in hypertension and diabetes, which allows us to send our patients home with the cellular cuff. They transmit either their blood pressure or their blood glucose, and a nurse is monitoring that day in and day out. We also have transitional care management, which is the nurse who follows our patients when they have ER and hospital visits. Our newest addition is advanced primary care management. And that one really is just a merge of all the services above for a more vulnerable population. Now, while all these core programs are important, what's even more important is the infrastructure behind it, right? So we invested very heavily into standardizing workflows and documentation, to integrating population health, and to really tightening our referral and medical records processes. Because we understood that without that foundation, none of our clinical programs were going to succeed. All right, this is a not so pretty diagram of the structure of our care coordination department right now. On the left, you'll see our care coordination manager. This position oversees all of our frontline clinical staff, which includes today 6 nurses that either do CCM, RPM, or TCM, as well as a care coordination admin. And this position is really important because all of our enrollment and our assignment funnels through that position. So she's scheduling transportation, she's making sure care plans get mailed out, she's triaging phone calls and messages. She really allows our nurses to focus on direct patient care. Then we have our data analytics and population health team. They're another unsung hero, right? They are the team that's giving us the data to move from reactive healthcare to proactive. So they're studying our patient populations, they're identifying gaps in care, and then they're communicating that information back to our teams. On the right, you'll see our medical records manager and referrals manager, which oversee their respective teams. Medical records is vital in making sure we get accurate, timely information back to our providers and our nurses. And the referral specialists work hand in hand with our CCM nurses to make sure that our patients are actually getting in to see their specialists. So yes, it's a nice diagram, or maybe not a nice diagram, but what I really want you to see here is like, this is not just an organizational chart. This is an integrated system, right? All of the teams here are interdependent. And when this structure works, then you see more efficiency, streamlined processes, our patient and our provider experience is better. All right, so this is really our core program. We started with chronic care management. Everyone always asks, because I'm a pharmacist, they say, like, how did you get to Christ Community? You know, what made you go there? And working in retail for 10 plus years, I would always get patients on the backside. Like when they're picking up their meds, I'm telling them how to take them and what side effects they should see. But that always got a little frustrating. I felt like I was too late, right? And so creating this program allowed me to meet them earlier in their healthcare journey. So these are for Medicare patients with 2 or more chronic conditions. We assign them to a nurse who carries about 250 patients. But with these patients, they're not just checking boxes. Like, they are building relationships day in and day out. They are entering the hearts and the homes of our patients. They're building care plans, but not just with goals that are important to the provider, right? They're asking the patient what's important to them. Like, yes, we want to lower your A1C, but you also want to be able to go fishing with your grandson in 6 months, or walk to the mailbox and back without losing your breath, right? So we're making sure that we're engaging the patient and the things that are important to them. They're optimizing medications, identifying deterioration early, and closing care gaps as well. But if you ask me, like, I always tell everyone, like, this is where the magic happens, right? This is where we really get the opportunity to build those relationships, and those relationships build trust in an environment where we can spend time with the patient, educating them on just small changes they can make day to day that really impact their health care. All right, financial sustainability. I know this is not necessarily everybody's favorite topic, but this is the question that really determines whether the models that we create can actually be implemented and sustained. So on the left, you'll see productivity targets. CCM, we asked that our nurses have 275 units per month, and 1 unit is equal to 20 minutes of patient care time. Now, that doesn't necessarily mean 20 minutes on the phone with the patient. It is 20 minutes doing care for that patient. And a lot of you are already doing that in your clinics. You're sending in refills, you're following up on referrals, you're sending DME orders, you're connecting with your caregivers. So what we're doing is just documenting time for things that you guys are already doing each day. And that equates to about 4.6 hours out of an 8-hour day being spent on those billable activities. For RPM, it's more about engagement, right? So we try to have about 85% of our patients send at least 2 readings a month, right? 2 readings a month makes it a billable service, but for us, we want to see a lot more than that. For it to be clinically effective, we ask that our patients at least send a reading every other day. All right. The thing that I love about this model is that it merges really, really good, excellent patient care with good business, right? So, for example, CCM, the annual revenue per nurse is $145,000 to $160,000 a year, while salary and benefits are roughly $65,000. RPM adds additional revenue, but also improves outcomes. And while we are just starting to bill and enroll patients for advanced primary care management, it seems that that is going to just allow us to extend the opportunity to more patients. All right, this chart just kind of shows our growth over time. You'll see like small gradual increase in our revenue to 2026, where we are projected, if we collect what we have if we collect like we have during the first quarter, to make almost $800,000 this year in revenue. And that doesn't include shared savings or dollars that we bring in from value-based care incentives. But when I look at this, I don't just think about the revenue that we are bringing in. To me, this shows the evolution of our care model, right? This shows how when you streamline processes, you standardize your documentation, you can start to see scalable growth. What I also see is the work of our team. This is our nurses being committed and loving our patients enough to learn how to manage their longitudinal care better, right? So yes, it's great for us to bring in revenue, but it really reflects the hard work of the team behind it. All right, clinical outcomes. We talked about structure, we talked about sustainability, but none of those things really matter if we don't have good clinical outcomes. So these are just some of the things that we've noticed over the years. We have decreased hospitalizations and usage of the emergency departments near us. Our patients have better chronic disease control. Our staff, and this is a big one, we saw less staff burnout. So prior to chronic care management, our patients that are currently enrolled were very heavy utilizers of our phone systems. So they were calling all day. They were asking our nurses for help, just really navigating the cumbersome healthcare system. And our nurses were working long days. They were staying late, and then they were coming in the next day with a whole list of things that they hadn't completed. And so this really helped to engage those patients more, make sure they felt loved and cared for, but also allow our clinical staff to focus on clinical activities. What I think is even more important than these is how our patients feel being a part of this program. So it's not just these clinical outcomes that you see here, but it's the trajectory and the mindset of our patients, right? They feel more engaged and knowledgeable about their health care. I think they feel more empowered to take care of themselves at home, right? They are staying in their homes longer. They feel more dignity, more independence. And it's just because somebody took the time to call and check in on them every day and teach them how to navigate, things that are difficult for you and I to navigate. All right, so we're gonna make this a little bit more real with the patient example. We have AD, who's a 71-year-old African-American female who started our CCM program in 2022. She came, like many other patients, with multiple chronic conditions. So type 2 diabetes, chronic kidney disease, anxiety, depression, chronic pain. Her provider specifically asked us to work with her on her diabetes, her uncontrolled blood pressure, and her medication non-compliance. You know, a lot of people would look at this patient, well, not necessarily this picture because she looks extra healthy right here, but a patient like this and just say, okay, well, it's another non-compliant patient who isn't taking their meds, not doing what they're supposed to do. But what we saw was just another patient who needed just a little bit more support. All right, so after time in CCM, when we look at where the patient is today, her A1C is 6.3. Her average blood pressure over the last 6 months is 118/78. She has come off 3 of her medications. She has a better control on her depression and her anxiety, and she's made small but impactful changes to her lifestyle and her diet to help manage her conditions a little bit better. You know, how do we do this? Just consistency. Like, you see that she was enrolled in 2022, it's 2026 now. And so a lot of you ask, like, well, it took 4 years. Yeah, it did. It did. Because it takes time to build that trust with the patient, right? To show them that you are going to consistently show up and check on them and do all the things that you promised them you would do. And so our nurse just continued month in and month out to call her, to spend time with her, to check on her, to educate her. And in doing so, she noticed that the patient wasn't truly, yes, she's non-compliant, but she wasn't non-compliant just because she didn't want to take her medications. She was non-compliant because she was afraid of needles, right? And that's why she wasn't using her insulin. That's why her A1C was high. And we were able to connect her with behavioral health and just kind of slowly work through those things, which resulted in her being able to come off some of her medications. Also, some of her depression and anxiety was fueled by the fact that she was just lonely, right? Her daughter lived locally, but just didn't engage her as much as she would like. She was seeing a lot of her friends and church members pass away. And I really do think that our nurses' ability to see those things that may not have been apparent in an office visit were vital in helping her improve her quality of life. So I will let one of our patients say it a little better than I can, but I won't read this whole thing, but I will point out the things that I think were really important. So one, consistency. She says she calls to check on me each and every month, right? Or the confidence she has in her nurse. She says she's excellent at what she does. But most importantly is the relationship, right? She genuinely cares about me as a patient. Those are the things that we can't put on a dashboard. It's not a metric that we can put a number to, but it really is why everything works, right? So as we think about all the things that we've talked about today, from God's calling us to take care of our seniors well, from the different models that you can implement in your different clinics, to how we operationalize that, to me, what's clear is that this work is both deeply challenging, but incredibly rewarding and impactful and meaningful for each of our patients and all of our seniors. Sorry, I can talk about this a long time, but I won't bore you anymore. I hand it back over.
Well, thanks. Great. That was great. And Lisa, yeah, thanks. We just have one more slide, and that's it, and just some takeaways. God wants us to create and sustain just and thriving communities that care for seniors well. Number 2, locate and design clinics to be accessible and functional for seniors. 3, communication is important and can look different for seniors. 4, consider options, including home-based, geriatric clinics, PACE programs, etc. Maybe you've got some other ideas. 5, care coordination is now affordable for clinics. I mean, there are financial structures and models that we can tap into and it's also very effective. And so it's an essential part of caring for all patients, especially seniors. So lean into that. lean into these programs. If you have specific questions about, well, how do you do this? What are these structures or policies that have been put in place for all the things that Lisa described or for Bree described? If you have specific questions, I want you to reach out to any of us, but especially these two here, because these are the guys doing the hard work and really know all the details. And so, reach out to either one of them, and we'd be happy to share, all that we have and all that we know about it. So I think we have a few. Do we have time for questions? Okay, so do you have any questions? Yes.
Question, just a comment. Obviously, this is such a labor of love and so much effort from y'all, and I just need to you guys. I think probably all of us in this room have elderly people that we love, so just thank you so much for taking the time and introducing about it.
Yeah, thank you. I'll get you. I'll make one comment too. Like, as a physician, I still see patients, one day a week, and most of my patients are older now because I'm older, and they've kind of grown old with me. And I just love connecting them to our care coordination team, because they'll have a problem. Say, Dr. Campbell, I really need help getting this thing. I'm like, I got you. I'm sending a phone encounter to Shannon right now, and they're like, oh, great, Shannon does, I love Shannon. Shannon does everything for me, and they know Shannon, and they know Jackie, or they know Jessica. Like they're paneled with this one care. And one patient the other day looked at me. She goes, Dr. Campbell, I love you, but I really love Jessica. Because she talks to Jessica all the time, and Jessica gets stuff done for her. And so it's a wonderful relationship. Go ahead.
Did the behavioral health provider also do home visits?
Not, well, yeah, I can't answer it for everybody else.
No, it was just a clinical medical provider. It was either the APP, if that's what you're asking, or the, oh, sorry.
You said the example you gave, right? The case that you shared. Said the name this would be behavioral health, right?
Yes, but, I'm sorry. No, they did not do home visits. So when we connect them with behavioral health, we're just essentially doing a warm handoff. We're letting them know that behavioral health will either come to their next office visit or we'll give them a call. And then they continue to see that behavioral health consultant continuously.
But also, I wanted to echo something that was said by the first question, just how I love the fact that CCHF, we seek to serve the underserved. We go to the places that are marginalized, the most marginalized places in our society, and we set up shop. And that's amazing. That's the work of God. Older adults within those communities are a subset within the marginalized community that are often overlooked. And we often expect older adults to be able to fit within the systems that work for people that are not older adults.
Yeah.
And we don't consider these unique needs that our older adults have, especially considering the staggering statistics of how many people become quote unquote older adults every year, every day, right? And the trends that we're seeing for like 2060. So I think this is amazing.
Hey, let's get that guy on the panel next year when we do the talk. Let's get that guy on the panel.
Thank you. That's a great, and I would even push that further. So in our community, opioids have just ravished the lives of. There's almost no family we've talked to that is untouched, and so if you push that even further, there are peculiar issues within each of our communities that are particularly burdened by those issues, which are a problem everywhere. But if you get in some of our communities, some of the breakdown of the family system, some of the systems that can help folks in other communities aren't there. And so we are trying to think, even in ours, because addiction is a thing, about 30% of our folks struggle with addiction. And so there's some things that we're trying to specifically target in terms of support for them. Thank you for that comment.
unseemly hours for the patients from active. We've had patients actually, patients say, oh, we can't come back. We forgot. And that's an issue. And somebody, anybody who get in touch with somebody and create something better, transportation for our seniors, to be back and forth to the clinic, it would be so helpful.
Where are you from? I'm here. Cincinnati.
Yeah, it's really sad. Mrs. Barry, she was like, I'm so tired of waiting for paper. It's a bad day. Can y'all call me? Breaks your heart. You know, she's wondering, like, well, if I can get in the car, I'll take you home. No, that's part.
Right.
And so I know, for instance, when my mother was on dialysis, she would be like, I would be at work, so I couldn't take her. She'd be like, hey, I already go home, my business. She'd be like, so that is the issue. If somebody can get some transportation back for our seniors, it would be I'm pretty sure it's making nice money out of it.
Yeah, thank you for bringing that up. It is a really significant part of what we do in PACE. So that is actually part of the services that PACE is required to provide for our patients. But outside of that, I would say early on at Lawndale's, we've struggled with that too a great deal. We, at least in Chicago, have had programs where we felt like it was within our mission to give bus cards to people to be able to, who could utilize the public transportation available. But I tried to find some local folks who wanted to make a business of it. And so over the years, we did try to tap into some local folks that were, not the yellow cab, taxi cab. But I think with the onset of Uber, that has actually alleviated something. In Chicago, we have Uber Health. We have utilized them quite a lot for the transportation element of that. I think there's always a conversation or decision around how you fund it, right? So I think in early years when we didn't have specific funding for that, we made it rose to the level of importance, because really if those folks can't get in, I mean, if you can increase the number of your visits because you provide them transportation and then you can bill for the visits, actually it might be financially feasible to provide that in-house.
There's one more question up.
And actually, I'm going to organize a new conference actually. But then, I remember it very, very funny. One of the patients came out most of the kids anymore because they were and actually, I saw when I home, I realized I'm here. I've been trying to do today, I'm not sure what the purpose was. You are not only delivering Christ to patients, but, over into family and around the nursing home or, where they are at, and we can give good opportunity to pray to them. You share gospel and bring Christ because of their limitation, their illness. So thank you so much for, and it's such encouraging for me to see where you are at, when you follow them.
And chart your own course. I mean, thank you for those comments about home visits, but that was very much my experience as well. Thank you for that.
Let me pray. Let's pray for it. Let's pray about this. Father, you are so kind to us and good to us. And thank you for inviting us into this work that you have to care for the aging. And Father, for the resources you've given us to do it, Lord, would you continue to stir up in our hearts and minds ways that we can encourage each other and inform each other on how to do this better in our own communities. And Father, would you just pour through each of our communities, each of our neighborhoods and our clinics? Would you send your Spirit out to bless these communities and provide more opportunities and resources to show your love and to provide good care and to just bring you glory and to bring joy to seniors. And we pray all these things in Jesus' name. Amen. Okay, I think.
Thank you all for coming. We have a post-session survey to scan here. I'll hold it up and gesture it around the room here. And this does count for CME credit as well as other credits. If anyone wants them, feel free to come on up and sign your name.